I'm looking forward to sharing with you today how we applied an equity lens to some of this patient-reported experience data. As a quick background, and as I'm sure we're all aware, measuring patient experience through such patient-reported experience measures, or PREMs, as we'll refer to in this presentation, are not only a key part of the quadruple aim framework, but also allow OHTs to better understand the patient experience and fill in any experience gaps in care. When we also measure the social determinants of health alongside these patient-reported experience measures, we're better able to apply an equity lens to this work and evaluate and understand existing health disparities in the patient experience. The results we'll present today reflect, again, the patient experience survey that Walter has already mentioned, and results from a specific OHT. This OHT will remain anonymous for the purpose of today's presentation, but I have included a few aspects of their population profile to give you a sense of the comparability with other OHTs. Overall, this is an OHT with an attributed population of between 50 and 100,000, majority Caucasian, higher income, in a largely rural catchment. To further illustrate the relative socioeconomic status of this particular OHT, here we have all of the OHTs ranked by material deprivation, which is a combined socioeconomic status indicator using the indicators shown on the left-hand side of the screen. So what you're seeing in this graph are each row represents a different OHT, and they are ranked by the proportion of their OHT that falls in the most deprived catchment. So that dark blue bar represents the most deprived or disadvantaged. And with the red box highlighting the OHT in this case study, we can see that they fall toward the bottom of the graph or are relatively from a higher, a more affluent population. Walter mentioned previously that this patient health experience survey was developed using Carey Kolesky's model here. Today, I will be presenting not all of the results of this survey, but again, focusing in on applying an equity lens. And to do that, we will look at 8 specific patient-reported experience and outcome measures shown on the slide. Again, patient-reported outcome measures are standardized, validated instruments that are completed by patients to understand their own health and well-being, whereas these experience measures aim to capture the patient's experience of receiving care and their perception of the care encounter. This survey was distributed electronically to the throughout the OHT through the Family Health Team Registry. And for those patients that did not have an email address on file, they were sent paper copies of the survey over a 4-month period. When analyzing these survey results, we completed descriptive statistics and also ran a multivariable logistic regression to understand the relationships between those equity stratifiers and the patient-reported experience and outcome measures. First, I'll give you here a glimpse of our sample characteristics. You can see that most of the respondents were seniors. More of the respondents were women as compared to men, which likely responds to the intensity of use of primary and other healthcare, but is not representative of the full population or of the OHT. The vast majority of responses were also from individuals who self-identified as white and heterosexual. There were 3 socioeconomic status indicators used in this study. Difficulty paying bills was used, and we also referred to that as income security, having enough money left for food or food security, and finally, worrying about losing your home or housing security. To give you an example of how these socioeconomic status indicators were assessed alongside a patient-reported outcome measure, here we have self-reported health by socioeconomic status. The only one of these associations that was statistically significant was that of income security. And here we can see that those who were always struggling to pay their bills at the end of the month were also, or who were the most income insecure, also had the highest proportion of self-rated poor health. I mentioned earlier that 8 patient-reported experience and outcome measures were our variables of interest for this particular study. So here we can see them actually fleshed out as full survey questions. Again, assessing items related to the patient experience with primary care, asking things like length of time to access your healthcare provider, whether your provider listened carefully to you, whether you felt understood. We created two-sided or dichotomous variable from one of the questions, and this was, in the last 12 months, how would you describe the length of time it took to access your regular healthcare provider? So here we can see the results of this specific question, with about 70% of respondents feeling the length of time was about right, whereas about 30% of the respondents felt it was somewhat or much too long. Now we'll expand our look at this specific length of time to access care question, now using our equity stratifiers. So these are the results of the logistic regression, both those that were statistically significant and otherwise. Down the left-hand side, you will see the different equity stratifiers that were used. And again, compared to those two groups who felt their care was received in an appropriate length of time versus somewhat or much too long. The statistically significant results are marked with a star, 1 or 2 stars. So you can see that age, there was a statistically significant relationship with both age and housing security. So to illustrate that in a written interpretation, here we have the results. So compared to those who were 65 plus, younger adults were more likely to indicate that their length of time was somewhat or much too long. And we see that those in the 18 to 44 age bracket were 39% more likely to report this, whereas those in the 45 to 64 age bracket were almost 50% more likely to report length of time as being too long. There was also a statistically significant relationship when it came to housing security, whereby those who rarely or never worried about having a place to live, compared to those who were housing secure, those who were insecure with their housing were 25% more likely to indicate that the length of time was somewhat or much too long. Now, we do have the results in a table format like we did for this access and length of time question shown previously, but for the purpose of today's presentation, I'll now shift to share only the statistically significant results by equity stratifier. So on this first slide here, we have the statistically significant results by the stratifier of age. And there existed a trend across all of the experience and outcome measures included, whereby younger adults reported less favorable experiences. So if we look at this specifically, we saw younger adults having lower odds of perceiving their wait time as about right, which we've already shown, feeling their healthcare provider understood their health needs, reporting their healthcare provider listened carefully to them, perceiving their healthcare as coordinated, and so on and so forth. Again, these were younger adults having lower odds of this. When it came to the results by socioeconomic status identifier, so again, though that was our housing, income, and food security, we saw several statistically significant results, and in each case, those who were insecurely housed, had lower income security, or had lower food security, had less favorable patient-reported experiences. And finally, when we look at the results by gender and sexual orientation, there was one statistically significant association between gender and feeling understood by your healthcare provider, where men had lower odds of feeling that their healthcare provider understood their needs but there were actually no statistically significant associations between sexual orientation and any of the PREMs or PROM included. In terms of limitations, as you saw both by the sociodemographic profile of this OHT as a whole and by our study sample, there may be limited generalizability based on the relative lack of diversity of this OHT and of this study sample. There may also be the case of a non-response bias, whereby those who didn't respond were from equity-deserving groups and may have had less favorable views of their patient experience. This would lead to underreporting the results we showed today. But in summary, given the worldwide focus on addressing equity, widespread assessment of patient experience and outcomes alongside such social determinants of health is important, particularly as a tool to promote person-centered care. And in the specific context of integrated care, attention to barriers and enablers for equity-deserving groups accessing both health and social care services and transitioning between these services should also be investigated. Do feel free to follow up with me directly if you would like to engage with any of this material. Thank you very much.